Welcome back to the continuing evolution and history of RxP. Today we present part 2 of my conversation with Dr. Glenn Ally. In part 1, we discussed the origins of the RxP movement in Louisiana, from the first legislative efforts to the development of Alliant's MSCP program, which was the first in the country, to the historic first prescriptions written by psychologists in 2005. Today, we pick up that story, exploring how prescriptive authority has grown, the role of the American Psychological Association, and the ongoing challenges and opportunities facing medical and prescribing psychologists. So, let's continue. There's so much more I want to ask you. So, we'll return to the state as well as want to talk about national things a little bit. But one aspect of this I was kind of curious about. So, in New Mexico, when the prescriptive licenses were finally issued, there was a bit of a retaliation that the initial prescribers experienced. In fact, Maria Marquez had a complaint filed against him by the medical board, for ethical practice. And of course, it was unfounded and eventually dismissed, but it was clearly in retaliation for
Yes.
this. I was wondering whether you guys experienced something like this in Louisiana.
Well, interesting, and that is a longer story, but interesting kind of thing. Initially, our statute had the 3 C's in it, what we called the 3 C's. That is consultation, collaboration, and concurrence. Before we could prescribe a medication for a patient, we had to have consultation, collaboration, and concurrence from their primary care physician. Okay. So if they didn't have a primary care physician, we couldn't prescribe for them. But that initial concurrence was a difficult process for those of us who had a hospital practice, because there were occasions when the patient wasn't admitted by their primary care physician. They were admitted by a specialist, like a cardiologist or someone like that, so that it was difficult and cumbersome on the medical psychologist, and it was also difficult and cumbersome on the physician who had to consult, collaborate, and concur before we could write the prescription. Very often we heard from the physician, well, that's why I consulted you, so you would prescribe. Why are you calling me again? And there were occasions when physicians would say, no, we're not, I wouldn't consult or concur with any medical psychologist. So we did get a little pushback initially. In fact, 2 quick stories. One was I called a physician, said, I have this patient, I'd like to prescribe this medication, such and such a dose, blah, blah, blah. And he said, you're a medical psychologist? I said, yes, I am. And I had told him that at the beginning. He said, I will never consult with a medical psychologist, and hung up the phone on me. Okay. Fast forward 5 years, my colleague and I are at the community mental health center, and that physician comes into the community mental health center to seek a job. And he is now consulting with us at the community mental health center. And he is one of the staunchest supporters of medical psychologists. But initially, because of the publicity, he did not want to consult. Second story was there was a unit in the general hospital, a psychiatric unit, inpatient unit. And I happened to be consultant with the inpatient unit. The medical director and another psychiatrist were operating the unit. And he and I knew each other. We played golf once in a while. He called me into his office. He said, Glenn, are you involved in this prescriptive authority movement? I said, yes, I'm very involved with it. He said, I am sorely disappointed in you. He said, I would never have you write prescription for anybody on this unit. I said, you don't have to worry. I don't have to prescribe for anyone here. I don't have to do that. I'll continue providing group therapy and individual therapies and those kind of things, but I don't have to prescribe here. Next year, the other physician, the other psychiatrist leaves. So he's there by himself as medical director. He calls me in his office again. He said, Glenn. I said, yeah. He said, I like playing basketball on Wednesday evenings, don't you? I said, yeah, I know you've been playing basketball a long time. He said, and there's some weekends that I want to get out and go fishing and do things like that. He said, would you mind taking call with me? So now he wants me to take his call while he's playing basketball and going fishing and things like that. Okay. So now he likes medical psychologists. So necessity sometimes makes strange bedfellows.
Right. And there's such an important message in what you're saying here to so many states. And of course, we've seen that happen in other states, in New Mexico, of course, in Illinois, where there is a lot of initial pushback from medicine. I think a lot of the medicine really has come around. Something that I kind of connected with when you were saying is, the concurrence model is kind of something that Colorado is dealing with right now, right? And just like you guys have been able to overcome it and gain more independence over the years, I think that's kind of what folks in Colorado are hoping will occur with that over time.
You say we overcame it. There was some push to that as well. As you know, we passed another RxP statute in 2009. Okay. That was out of necessity. What happened was we became a very strong political player in the state. And the medical society wanted to not only have us on their side, they wanted the people that we have as lobbyists to be their lobbyists. Story goes that they had a lobbyist for 13 years, the Louisiana Medical Association. 13 years their lobbyist was there. When she lost the bill, our bill, they let her go. They fired her. Okay. So they were after some lobbyists and they wanted our lobbyists. So they approached us and said, we're going to pass some rules. What do you think about these rules? And they gave us a copy to read. And the rules made it extremely onerous for any physician to consult, collaborate, and concur with psychologists, with the medical psychologist. So I got on the phone with APA and we talked about it back and forth. And we had for a long time said we were going to go for, we called it the big enchilada. And that was independent prescribing, so that we didn't have to do that consultation, collaboration, concurrence before seeing the patient. So this was our opportunity. Person who was the executive director of the Louisiana Board of Medical Examiners, LSBME, was a physician who was a hospitalist. He was an internal medicine hospitalist. And he had no problems with medical psychology prescribing. So he and Dr. Quillen and several of us sat down and he presented to us, he said, what if we could find a way that you guys could prescribe rather independently, but be under the medical board? He said, we would like everyone who's prescribing to be under our tent. He said, you guys do a great job. He said, we want you under our tent. So we talked about it and we went back and forth. And what they offered was medical psychology advanced practice. So the advanced practice medical psychologists get a little bit more training, a little bit more education. They do not have to do the consultation, collaboration, and concurrence before. They can get consultation and collaboration after the fact, after prescribing, and the concurrence is no longer there for the advanced practice. So that was a carrot that they kind of dangled in front of us. And we tossed it about and we said, it's something that we can do. There were some other things that we put in that second piece of legislation that was extremely important. After 2004, that legislation gave us a certificate of prescriptive authority. it was added on to your license as a licensed psychologist.
Which is the way it's done in New Mexico, for example.
The new statute now identifies in statute a separate profession, medical psychologist. So it is there's a psychologist in statute and there is a medical psychologist in statute. No other specialties are in statute. Okay. So that was extremely important to us to have that independent prescriptive authority and to recognize this as a distinct kind of profession. So 2009, we introduced a bill which moved medical psychologists from the psychology board to the medical board. In addition, it gave us the profession of medical psychology with license and licensed by the medical board. Dr. Marier, Robert Marier was the executive director of the Louisiana State Board of Medical Examiners, testified before the legislature in favor of our bill and said a very, very important quote. He said, "We know these guys are safe prescribers." We never heard the issue of safety after that. He said, "We know these guys are safe prescribers." And that is documented. It's not podcast, it's streaming, but whatever it was, that is documented and that is there. Okay. The other thing that the medical board did for us, which was very helpful, is the medical board issued an opinion saying that medical psychologists are qualified to do evaluation and management codes, E&M codes. Now, it hasn't helped so much with Medicare. The prescriptive authority of psychologists with Medicare is still somewhat problematic and has been so forever. We have on record and we have an opinion, a written opinion from the medical board that medical psychologists are qualified to do E&M codes. And it's been helpful with other insurers in the state because we had that statute before. I said that we passed long ago, freedom of choice. There's a statute that says if this service is provided and reimbursed by insurance, if it's provided by a psychologist, the psychologist cannot be discriminated against. So that, the statutes are there for us.
Right. When I speak with a lot of folks about this, students, prospective students, even some other psychologists, the decision to move MPs in Louisiana under the medical board typically raises two concerns, and I'm curious whether or not you can just speak to each one of them just a little bit. One of them is that being under the medical board now potentially opens medicine to begin to restrict our practice to a significant degree because we're now under their board, and their board primarily being made up of medical doctors, right? Not medical psychologists. Their board could pass, more onerous regulations for us.
Well, it's possible, entirely possible. However, we have also in statute what's called the Medical Psychology Advisory Committee to the medical board. And that is composed of 4 medical psychologists and 1 psychiatrist who is approved by LAMP, actually, by the Louisiana Academy of Medical Psychologists. So we get to approve the psychiatrists that they put on the Medical Psychology Advisory Committee. And it operates very similar to some of the other professions that are under the medical board. We think only medicine's under the medical board, but that's not accurate. I mean, there are other professions, lab techs, a lot of other folks are under the medical board. And they usually rely on the Medical Psychology Advisory Committee to advise them on any changes in statute or anything like that. So we haven't had a problem with that at all. The other factor that comes into play with this is they don't know what we do and how we do it. And they rely on us to tell them what we do and how we do it, so that we've had some complaints with psychologists, medical psychologists in the state, and those complaints basically have revolved around psychologists. We had one complaint of a psychologist delegating prescriptive authority when he wasn't there to someone else, someone else in his office, which he wasn't supposed to do. I mean, we've had some complaints like that, but nothing major in Louisiana. Again, medical psychologists seem to be very safe prescribers. I agree with Dr. Marie. The medical board has been cooperative. We've now gone to another executive director. Dr. Marie is no longer there, but we have another medical director. He's a former OBGYN doc, and he's very supportive of us. I mean, just as supportive as all get out. And again, about relationships, he and I have dinner once a month, at least once a month. Okay. So that we talk about things. And Dr. Quillen was the initial president of the MPAC, or Medical Psychology Advisory Committee, until he passed away. Then Dr. Lowe, Warren Lowe, is the current president. I'm the secretary of the Medical Psychology Advisory Committee and have been so since 2009. Now, when I say Dr. Lowe and Dr. Quillen, you have to recognize that we went through the same program together. We went through Southern Mississippi's PhD program. So we have a long history, way back, way back.
The other concern that I also hear sometimes, and I wonder if you can comment on that for us. To become a medical psychologist in Louisiana, one has to be a licensed psychologist first.
That's correct.
Then, while holding that license, if one has passed the PEP, of course, has the MSCP, all the credentials are in order, then one applies for the medical psychologist license. Once that medical psychologist license is granted, the psychologist license can be then let go of, can be given up.
Correct.
So some people feel that perhaps our identity as practicing professionals changes when we're no longer now licensed by the licensing board. I wonder if you have some thoughts.
Yes, that is essentially correct. In other words, the statute reads that if you're coming to Louisiana to apply to be a medical psychologist, you must be licensed by the psychology board first. Then you apply for the medical psychology license with the medical board. Once that has been granted, you have the option of keeping both licenses, or you can drop the psychology license. Yes, that's correct. I had years ago written a little article or something on our psychologists becoming a junior psychiatrist. And we found that not to be the case, that psychologists continue to do psychotherapy. They continue to do various forms of diagnostic evaluations. We are still trained as psychologists first, and we look at things through that perspective. It's a different perspective. We genuinely do the biopsychosocial model of things. We use all models, the bio model, the psychosocial model as well. I've said before, and I'll say it time and time again, I think we're in the best position to apply the model or the tool that the patient needs, not force the patient into the only tool or only model we have.
One of the points you're making, and I think it's an excellent point for everyone to keep in mind, and that is that it is really not the licensing board that defines your identity. That's what defines your identity is how you've been trained and how you think, what kind of interventions you utilize, because that's what you believe in as the curative model, right? And that doesn't change whether you're licensed by a medical board or by the by the psychology board or both. That's really in you from your training and experience that you've had to become a psychologist in the first place.
I agree wholeheartedly. Like I said, I was trained as a neuropsychologist, and I have not given that up. At the present time, I've retired from private practice. I still work 3 days a week at the community mental health center here. I've been there for 18 years. There was some pressure from the administration for prescribers to go to 15-minute medicine checks. And my colleague and I, who I talked him into going to community mental health center as well when we retired, both medical psychologists, we said, no, that's not what we do. We don't do 15-minute medicine checks. Said, yeah, I will not. I said, number one, good luck in getting reimbursed for that, because 16 minutes is the minimum amount of therapy time that you can bill for. Okay. Said, so good luck with that. Said, no, we're not going to do that. We are going to continue to do what we have been doing all of our professional career.
And research really supports that, because we've had verification of that now by at least two groups of researchers, one being Dr. McGrath and his group that did a paper a few years back about the patterns of practice of prescribing psychologists, and more recently, Dr. Hughes had also published some data on that, and both of these investigations show exactly what you say, which is that we continue to provide psychotherapy as an additional intervention, in addition to medication management, and that sometimes we don't even use medication management, even though we can prescribe. It doesn't mean that we have to. And psychologists are much more likely to utilize these other tools.
When I was in hospital practice, I was primarily concentrating on a rehab unit, physical medicine rehab, rehabilitation unit. Primarily what I would do there would be taking patients off of medications because they came from other floors on a ton of medication. If they complained of any symptom whatsoever, they got a medicine for it. I can't sleep tonight. Okay, take this medicine. My nose itches. Okay, take this medicine. And my role up there was to take them off of many medications so that they could function better and recover better. So yeah, we do look at things a little bit differently. The other unit I worked on was the cancer center, and there were many cancer patients that were on medications that were inappropriate, so that changing medications, doing medication consultation is one thing, but you still have to have that relationship with the patient. That's where our psychology training, I think, stands out more than any other in the field. Psychiatry has given that up, unfortunately.
Unfortunately, yeah. When I speak about this, whether in a classroom environment or in some other forums, I like to use the analogy of psychiatry nowadays kind of practicing bio, large, psycho, social, small segments, right? Whereas we are much more likely to devote equal attention to the bio,
Yes.
psycho, and the social, and really blend them
Yes.
together much more effectively. And the other saying here that comes to mind about psychiatry of a prescribing in so many cases is, especially with them now have given up, like you said, largely the psychological interventions, which is unfortunate. So they all saying, when the only tool you have is a hammer, every problem looks like a nail, right? So
Exactly.
when you have that prescription pad as the primary intervention that you're going to utilize, then more patients are going to leave with prescriptions with multiple medications. Whereas we have the training and we practice the balanced approach.
I had that discussion, call it what you will, on the listserv, the psychology listserv, with Dr. George Albee. Uh, Most folks know Dr. Albee, and he was not necessarily in favor of prescriptive authority for psychologists. And my argument to him was that, why do we continue as psychologists to sort of negate or throw out the biological model? It's a fact. It's there. Why don't we just deal with it and become part of the biopsychosocial approach? Because I think that's an important aspect of it. And you know, it's just something some of our colleagues understand and appreciate it. And we still have some colleagues who think it's not something we should get into.
Something I've been wanting to ask you and kind of go into this whole area for a little bit in our talk today, and that is on the national level, and especially having to do with APA. How did APA react to the early RxP efforts in the 80s in Hawaii, but that didn't go anywhere? But starting in the 90s, of course, we had the DoD project, and then the states started to pass RxP. And you had been involved in APA in this for a long time. I wonder if you can talk a little bit about the early days at APA when it comes to RxP and how APA has eventually come around.
I think APA was very, very much in favor of moving that forward. Under, if you recall, the APA was led by Dr. Russ Newman at the time, and the practice directorate, remember, it was separated. There was a practice directorate, was Dr. Mike Sullivan, and they both were extremely supportive and in favor of prescriptive authority. I don't know how involved they were in the New Mexico model in the very beginning to help New Mexico get it passed, but I understand that they were involved with them. And Dr. Newman wanted to have a second state to show that the first state was not a fluke. Now, Dr. Newman was involved in getting the DoD project, the PDP program, off the ground and basically getting it going and seeing over that program the entire time. So he was involved with prescriptive authority for a long time. Dr. Newman was not only a psychologist, but he was an attorney as well. So he was familiar with statutes and what needed to be done to pass statutes and lobbying and the whole 9 yards for APA. So APA was very, very supportive. Again, APA developed a model. The states had actually passed a statute. APA had that model on the shelf. And APA was extremely supportive financially. Our statute in 2004, I told you before that the optometrist said it would take about $250,000 to pass a statute. We were just shy, and I mean very shy, of $1 million. The APA spent, I think, something like $350,000, and the medical psychologist here in Louisiana put up at least $600,000 to get that passed. Those 50 people put up a bunch of money to get that passed. But APA was always supportive. I was involved in, and not only on council, representing Louisiana on council, but once I got on council, I was elected to CAP, which is the Committee for the Advancement of Private Practice, or the governing board for the practice directorate. And I was appointed to the chair of the RxP committee at that time. So those early days were about getting everything that we could, not only financially, but in line to help states pass RxP. But we also had to do something else, and that is we needed to develop a national examination, because in order to be licensed, most places require that you pass a national psychopharmacology examination. So the PEP, which was developed at that time, came about. And Dr. Bolter helped develop that as well for APA. So John Bolter had his fingers in a lot of all of this. I can't say enough about how supportive APA was and continued to be. On the CAP committee that oversaw the practice directorate, I was obviously a very vocal voice for RxP. I spoke before council to support it. I had to argue for the medical psychology term rather than the prescribing psychology term before council, and a couple of things. But like I said before, it's about relationships. While I was there, I developed a relationship with two other psychologists, Dr. Sandy Portnoy from Massachusetts and Dr. Paul Burney from Texas. We would meet before council, before CAP meetings. We'd have a little toddy or something like that at one of the local hotel lounges, and we would discuss strategies, what we needed to do to get things passed. Now, Dr. Burney and Dr. Portnoy were not medical psychologists. They had no illusions that they were going to get prescriptive authority in their state anytime soon, but they wanted it to happen. They were very forward thinking individuals. And I started aligning myself with a lot of forward thinking individuals at APA. Dr. McGrath, Bob McGrath. Know Dr. McGrath very, very well. Okay. And once Louisiana got their statute passed, Dr. Quillen and I would travel to some of the other states, Washington State, several of the other states that were putting forward prescriptive authority, Missouri, others, Florida, others that were putting forth bills to kind of help them along and coach them along. I still today get emails from some of the other states wanting to do certain things. Dr. Ron Reimer, uh, she was very supportive as well. She got Illinois to pass their bill in Chicago. The APA was very, very supportive. However, after Dr. Newman left, there was a conversation on the telephone that Dr. Quillen asked if I would take the call because he was upset with APA. And APA had basically threatened us, saying that they were not going to financially support us anymore. This was right before the 2009 legislation, and that they had given us enough money and they weren't going to support us anymore. It wasn't Dr. Newman, it wasn't Dr. Sullivan. They had both already left. We said, okay, well, we'll just have to find another friend to help support. And, we did. We went our own way, basically. I was disappointed in APA's response to a couple of things. Number one, changes in Medicare. That has been promised for I don't know how long, and it hasn't come about. The other thing was we had suggested and talked to them about insurance, liability insurance. And APA was sort of throw their hands in the air and didn't know what else to do about it. They directed us to the insurance trust. So Dr. Quillen and I talked to the insurance trust. APA didn't do it for us. They left it up to Dr. Quillen and I to get the insurance trust. Was the only insurance program writing liability insurance for prescribing psychologists at the time. So hats off to the insurance trust. Uh, little things like that, things that turn out to be big things, but little things like that were problematic with APA. We talked to them about it a long time, about getting psychologists to prescribe in the VA. You would think that is a simple kind of task to do, but it's not. We can prescribe in all branches of the military, but we can't prescribe in the VA still today. So that there are some things that I think APA could be doing, but I think APA is on to other things, and prescriptive authority is sort of taking a backseat to where it should be, in my opinion, anyway. I think we should have more states.
And I wonder whether or not some of it had been due to the momentum, at least temporarily, slowing down after the first two states. I mean, all of us who were in this from the 90s, some of us even before then, right? But I started to be interested in this and active in this in the late 90s. And as we were going through our training at the time, we were all kind of thinking, especially after the success in New Mexico and Louisiana, that the other states were going to kind of fall one by one relatively quickly. And that hadn't happened.
Yes.
So I was wondering what your thoughts were. Why, in New Mexico and Louisiana, those efforts were successful, but why more states were not successful initially?
Interestingly, it's the same thing that the optometrist told us when we met with them, even before passing our statute, that they had gotten two states right in a row, and then it was another 10 years before they got the third state. So it doesn't seem to me unusual in passing legislation state by state by state. Look at Hawaii. Hawaii's been introducing legislation since 1985, and they passed it a couple of times, but it was vetoed by the governor. So they've done the work. Can't fault them for not doing the work. They have done the work, moreover. But little things, sometimes it takes a little bit of luck with it.
Do you have some advice for states which are thinking about fighting the fight and introducing RxP legislation?
Yeah, yeah. Obviously, as I said almost at the very beginning of this, it's about relationships and it's about money. In Louisiana, there's an emphasis on money, okay? But it's all about relationships. We have to make those relationships that traditionally psychologists really didn't get involved in the political atmosphere. Uh, but we have to. I mean, we are a profession. We are licensed by the state to do what we do. The state grants us that license, not APA, not your local psychology association. It's the state that grants you a license to do what you do. In order for you to continue doing that, work with the state, work with the legislature, get to know your representative, get to know your senator, get to know your governor, get to know the people who make a difference. There was nothing for our lobbyists to call. I mean, that first 50, that group of 50, the first class and the second class, the lobbyist he would call me like on a Tuesday in the middle of the day and say, I need you in Baton Rouge tonight and bring a check, and you drop what you do and you go to Baton Rouge where the legislators are and you make those acquaintances. You do what you have to do to pass it. Do you pass anything just to get a piece of legislation passed? Yes and no. I think, yes, you pass what you can, pass what your state legislators will approve. At the end of the day, it's about that legislator pressing the yes button and not pressing the no button. So whatever that legislator needs in order to press the yes button, help them with it. Help them with it. Okay. The nose under the tent can be helpful. We put nose under the tent with our bill and we changed it along the way. As the opposition became less, as the opposition got to know us more, we were able to move in a positive direction to get more. So sometimes it can be helpful. There are some states I know they tried it here, and some states have allowed it to happen that they will restrict the prescriptive authority to certain age groups or certain diagnoses in some state. Genders. Uh, they tried in ours when I said it went to the Senate floor. They tried to amend our bill to move out kids so that we didn't prescribe for kids. They tried to move out pregnant women. They tried to move out geriatric patients. And that was all voted down, thank goodness. But some states will allow that to happen in order to get the bill across.
Probably the most um, extreme example of that is what happened in Utah, right? With a bill passing, but currently the only classes of medications that prescribing psychologists can prescribe are not just antidepressants, but the SSRI type antidepressants. It's limited to that.
And some of them only for FDA indications, for off-label prescribing, which is difficult sometimes. But you get what you can, and then you go back and you get more if you can.
What's your advice for psychologists thinking about coming to Louisiana to become medical psychologists?
Yeah, we were concerned about that in the beginning, about psychologists just pouring here and wanting to prescribe, and we haven't had a significant influx, but we have had some psychologists come here and begin prescribing from out of state. We thought it would be neighboring states. We don't have that many from Texas. We have a couple from New York. We have a couple from Florida. We have a couple from other states come and prescribe in Louisiana. I think one of the things that scares them is that they have to be licensed by the psychology board first. And, that's an expensive process. It's an expensive process to be licensed by two boards. And then, you can always drop the psychology license, but it scares a lot of folks away. But, we're open to it. We have never been closed to that. However, we put some things in statute to try and we wanted to maintain some contact with folks who are licensed here as medical psychologists. You do not have to be a member of LAMP. That is not a requirement, but it is a requirement in the continuing education section of our statute that you have 25% or at least 5 hours of continuing medical education through LAMP, through our organization. That was another bonus that we got in the legislation. LAMP is in statute as a continuing medical education provider. So we can provide continuing medical education, and we do. We have 3 meetings a year. LAMP has 3 meetings a year. And in those 3 meetings, if you attend all 3, you will get all of the CME and CE that you need to maintain your license. So we provide it all.
And of course, a number of prescribing psychologists who then became medical psychologists have moved to Louisiana.
Yes. Yes. Well, we have one who moved from Louisiana to New Mexico, Dr. John Courtney.
Right. Of course. Yes. A good colleague of mine for many years now.
I like John. Nice guy.
On a personal level,
yes,
becoming a prescriber, and you've been doing this for more than 20 years now as a prescriber. Talk a little bit about your personal experience. In what ways was it like you expected? In what ways was it maybe not like you expected? Some unexpected, aspects of it that you've encountered.
I had always been, like I said, in clinical practice, right out of school and internship, or I went right into private practice. So I've always been in private practice, and part of that private practice has always been a large hospital practice. I've enjoyed a big hospital-based practice. And during that process of my training and my internship, I interned at Malcolm Bliss Mental Health Center in St. Louis, Missouri, which was a 400-bed inpatient psychiatric hospital. We got all of the psychiatric patients for the first 90 days and then made some disposition thereafter. Okay, so we saw it all. And it was always asked of us, what do you think I should prescribe? What do you think? So we were always consulted on prescriptions, but never had the authority to prescribe. So I was comfortable with that. I was comfortable with making recommendations about medications even before I had the prescriptive authority. I was comfortable with it. The other thing was I saw the need. I saw the need to have that patient it was more for the patient than for me, but it was more of having that patient have a one-stop shop so that I could prescribe their psychotropic medication without having to call their primary care physician, who maybe knew very little about psychotropic medications, and ask them to prescribe a medicine for the patient. Well, I don't know. I don't know about that medicine. I usually don't use that in my practice. Well, okay, so now what do I do? So I was comfortable with it. I thought it was helpful for the patient. I thought it was helpful for my practice that I could provide the services right then and there without having to go through this process of another visit with another doctor and talk to that doctor for hours on the phone. It was easier for me to do that. So I felt comfortable with it. I just needed the knowledge that went with what I was recommending and the knowledge about what not to recommend too, so that I began to recognize the value of a medical school education, but I also recognized how important that medical school education can be with the psychology education. I mean, it's extremely important. I've often said psychology is a wonderful dual degree with just about anything. Psychology and law, psychology and nursing, psychology and medicine. Psychology is a great dual degree to marry with any, I think, other degree. So for me, it was very easy. Dr. Quillen had approached me when they were beginning the class, Dr. Bolter and Dr. Quillen. Like I said, Dr. Quillen and I went through PhD training together, so we knew each other for a long time. He said, Glenn, I want you to be a part of this class. And that was the first class. And the first class started, remember, in 1998. Well, I was president-elect of LPA in 1997. So I was going to be president in 1998, and I was going to APA. I said, Jim, I really can't. I don't have every other weekend to give for the next 2 years. So after APA, after I'm finished with APA, after I'm finished with LPA, Louisiana Psychological Association, then I'll be a member of the second class. I promise. So I became a member of the second class. And I tell you what, George, it was probably the best education I had, bar none. Better than my PhD program, better than master's program. It was a great education. And one of the things that's very, very different, I see why medicine now has this camaraderie and this brotherhood and this stick togetherness. Okay. Those 2 weekends, every other weekend, spent together with my colleagues in an environment where it wasn't competitive, see who could make the best grade. It was supportive to see who could help each other get through this program. And we endured things like pregnancies, we endured things like cancer, we endured things, heart attacks, the whole night, but we pulled together as a group. And that was the most fantastic experience that I've had in terms of education. Knowledge, okay, wonderful. But that experience, that education experience was just wonderful. I wouldn't trade it for anything.
This was an amazing conversation, very thought provoking, very important to be able to be aware of some of that history and learn from it going forward. I wonder if you have any final thoughts, anything that maybe you wanted to get to that we didn't have a chance to talk about.
Well, if one is contemplating becoming a prescribing or a medical psychologist, my advice would be just do it. Do it. Okay. You will not regret it. We have people who have been trained who have not become licensed. They decided they didn't want to go through the licensing process or whatever. Okay. For whatever reason, but they still speak loudly about the education that they got and the learning, the material that they've learned in going through this process. So that if you're contemplating it, if you're thinking about it, do it. You won't regret it. I promise you won't regret it. Okay. You asked about are there any drawbacks or any things that I would be concerned about or anything like that. My practice did change. Obviously, when you start prescribing, your practice does change. Okay. I have to deal now with more calls. Before as a psychologist, as a neuropsychologist, if I got, 2 or 3 calls a month after hours, that was a lot. But now it's 2 or 3, 4 a week that I get after hour calls about refills, about this, about other kinds of things. The answering service calls me about 3 times, 4 times a week. So there's that. There are drug seekers, people who want benzodiazepines or amphetamines or things like that, that you kind of have to screen out. I didn't have that before in my practice, but you have to deal with that. People think that there's a large insurance liability premium. It's not the case with the insurance trust. Dr. Quillen and I negotiated with the insurance trust. In fact, you can thank Dr. Quillen and some of us early guys for several things. Your DEA number, Dr. Quillen did that. He negotiated with them. We're still considered mid-level providers, but he's the one that got the DEA to recognize us and provide DEA numbers. NPI, you can thank me for that at APA. I was the one who talked to the people about NPI numbers. We are prescribing parentheses medical psychologists. Okay, with the NPI. Insurance. Again, Dr. Quillen and I talked to the insurance trust. The insurance trust wanted to charge us 20% of our premium to add on prescriptive authority. Dr. Quillen and I wanted 10%, and we negotiated and settled for 15%. And the reason why I thought that was so important is if you do 15 credits of continuing education with the insurance trust, that will wipe out your 15%. Okay. So it can virtually cost you nothing to have the added liability insurance if you do your continuing education with the trust. So the trust has been extremely good to us over the years. So all those early things that we don't think about, that you can thank Dr. Quillen, Dr. Bolter, and the crew that were the early pioneers.
Well, thank you, Dr. Ali, for everything you've done for this profession, the role that you've played in getting this going in Louisiana, nationally. The influence. Louisiana has had a great influence, along with New Mexico, on the nation looking at RxP as an option, right? And gradually embracing it. Thank you for being my guest today. This was an amazing conversation, reviewing so many important aspects of this whole history that is really good for us to remember and learn from as we go forward. Once again, I'm Dr. George Kapalka, the director of
Thank you,
the
George.
CP program at Alliant, the California School of Professional Psychology. So thank you, everyone, for tuning in, and we will see you at our next installment of our psychopharmacology podcast series.